Dr. Kathrin LaFaver. I'm a neurologist in Saratoga Springs, New York. And I have the pleasure today to be talking with Dr. Kim Robeson, who is an associate professor of neurology at Albany Medical Center, as well as the residency program director there, and a neuromuscular specialist. Thank you, Dr. Robeson, for joining me.
Thanks for having me.
Great. So I have the pleasure of working often closely with you on my patients, but I see in my general neurology practice and sometimes need a second opinion and expert guidance. So it's a really exciting time in conditions like myasthenia gravis, where we have really seen an explosion of new treatment options in just these past 5 years or so. I'm very pleased to take some time today to review some of these treatment updates with you and get some enlightenment, hopefully. So before we dive into the treatment, can you actually tell me if there is also some updates in the diagnostic algorithm for myasthenia gravis I should be aware of?
There are actually. So there's a couple more antibody tests that we can check now than we were historically able to do. I do always start with acetylcholine receptor antibodies, which is what we have been doing for years in myasthenia, and really should be the first line diagnostic test. But if those are negative in select patient populations, we now have several further options. MuSK antibodies have been around for a long time. We all use those in specific patients. But LRP4 antibodies are also commercially available now, and in the select patient population can and should also be checked. We don't entirely know the phenotype of LRP4 antibody-positive myasthenia just yet. We do think it's associated with both generalized and ocular myasthenia. I typically am checking LRP antibodies in patients who are seronegative, and particularly in those who may be more difficult to treat or not responding to treatment as I would expect, to really try and help confirm the diagnosis. I think the other big change over the last couple of years is our understanding of what some of the other antibodies mean, things like striational antibodies and titin antibodies, which historically have been associated with myasthenia, and we're starting to realize maybe not so specific for myasthenia. And in isolation, you should not jump to a diagnosis of myasthenia if you only have those antibodies at a atypical clinical presentation.
That's excellent information. And I think it's, exciting to see that the percentage of the seronegative myasthenia is really getting smaller, and we learn more details and hopefully will translate into more defined treatment algorithms. So talking about treatment, so talk us a little bit through, with the advent of some of these new options that we'll talk about in more detail, how has our treatment changed, and what should someone, who sees a patient with generalized myasthenia gravis, how should we kind of go about treatment in 2024?
So it's been a really exciting time for those of us who treat myasthenia. We have so many more options that work really well to treat myasthenic patients. I think the basics have not changed much. I still start with things like prednisone and acetylcholinesterase inhibitors. But we do have newer agents, in particular the FcRn inhibitors and complement inhibitors. Those are typically still saved for what we would consider more severe patients. Many times, in order to get those approved by insurance, a patient needs to have an MG-ADL score, which is a patient-reported outcome measure of 6 or greater, which are patients that we would consider pretty symptomatic with more than just ocular symptoms. And so if I have a patient that fits those characteristics and has more severe symptoms, and I don't have 6 or 9 months to wait for some of my immunosuppressants to start working, then it's time to start thinking of some of our newer agents like FcRn inhibitors and complement inhibitors. The choice between the two is really patient dependent. I think we have good evidence that both of them work. They've never been studied against each other, so no one has any idea which ones work better than others. But the mechanism of action and how we use them and the time course with how frequently people need them differs. And that's really what I use to help make a decision if I'm going to use one of these agents, which agent to use.
Got it. That's definitely, as you said, very exciting to have new options for especially the more severe affected patients. How does surgical treatment come into play? So the role of thymectomy.
I think that's also changed quite a bit in the last few years. And so we've always known that thymectomy is helpful for patients who have a thymoma, but we've for a long time not been sure what to do with patients who don't have a thymoma. And it's long-term been used as something that we use for patients with refractory disease. So once they're not responding to the things we have, we send patients for a thymectomy. But the newest evidence suggests that patients who are younger and typically under about 50 would benefit from a thymectomy, regardless of whether or not they have a thymoma. And so I am also sending my patients pretty early on, around the time of diagnosis, if they're under 50, to the CT surgeons to discuss thymectomy.
Got it. And then the benefit from thymectomy doesn't kick in immediately, right? So
Correct.
How are patients managed after surgery?
So it's often delayed for up to 2 years. And so the evidence tells us that 2 years later, the patients are on less medication. And so I treat them the same way I would treat my other patients until we're always trying to lower and get off medications. And we're more likely to do that if a patient has had a thymectomy before versus if they have not.
Got it. Yeah. So that's good to keep in mind. And again, exciting for patients to, if they're healthy enough to consider that surgery that might really help them in the long run and cause less disability in the long run. So with that being said, so you had kind of touched on that, but some of these newer treatment options are really mostly approved for antibody positive myasthenia patients. So how is the management different, or what other options do we have for people who are antibody negative?
So we still don't have approved medications for seronegative patients, but what antibodies they have also will play a little bit into what medications are approved. So most of the newer agents are approved for AChR antibody positive patients. There is one FcRn inhibitor, which is also approved for MuSK positive patients. And we actually know from retrospective data that rituximab is particularly helpful in MuSK positive patients. And so I'm still using rituximab pretty early in that patient population. But the seronegative patients, unfortunately, we're left with the standards that we've had for a long time, the oral immunosuppressants, and then things like IVIG and plasma exchange.
Got it. Yeah. Well, so with these newer options, we're hopefully reducing the amounts of hospitalizations for patients. But if someone is in a myasthenic crisis, how would you approach this, or do these new treatments come into play here?
So unfortunately, they're not coming into play just yet for crisis. We do know that they work quickly, and so I think they're helping to prevent crisis. So the benefit of both of these newer classes of medications is that onset is usually within a week or so after the first treatment. And so one of the issues we've had in the past is that once we start treating these patients, they often decompensate before our medications are effective. And we're finding that less often than we have in the past. Unfortunately, once they're in crisis, we have the standards we've always had, things like IVIG and plasma exchange.
Got it. So so hopefully more prevention and less need for hospitalization, but just definitely exciting. Well, thank you so much for this very helpful overview. So where can people go to read more, or also possibly find more information to print out for patient information?
So the Myasthenia Gravis Foundation of America is a great resource for both patients and providers. There's a provider section that has links to all of our current practice guidelines. You can find them at myasthenia.org. I also always encourage my patients to go there. They have a ton of patient-friendly information, cell phone apps where patients can do their MG-ADL themselves and then send me messages with what they are, and a lot of really helpful tools for our patients.
Wonderful. So that's definitely a website to bookmark. So thank you so much, Kim, for talking to me. I really enjoyed it, and I learned, as always, when I talk to you, I always learn something. So thanks so much, and thanks everyone for listening.